Thank you, thank you. I'm Dr. Don Blanton. I bring you greetings from Nashville. I don't play anything except my iPod, but I do have 15,000 songs on my iPod. I love music. So if you have any trivia questions or any music trivia to share, I'll be happy to talk. We're going to be, I'm board certified in internal medicine and emergency medicine. My career's been in emergency medicine. I was on the faculty at Vanderbilt when we created the residency program there in emergency medicine. They have an entire children's hospital now, but when I was there, the children's section of the emergency department was one hall down the side. So we saw all, took care of all. I've been working in the area of clinical documentation integrity for the past couple years. Don't need quite the adrenaline I did in my youth. So I'm traveling the country helping hospitals and their medical staffs negotiate all these changes that you've been reading about in the paper. So we're going to talk about ICD-10 for sure, but we're going to talk a lot about what's happening with those codes after they leave our office in the hospital. And we're going to talk about risk adjustments, quality, cost efficiency, analysis, the changing reimbursement environment, and some of the literature that defines conditions and the thresholds of severity within conditions, and how our medical language gets translated into the administrative, bureaucratic languages of processing the claims and some of the problematic areas of that. Well, ICD-10's coming October the 1st. There are not going to be any more delays. There was a big deal when ICD-10 was first announced about the dramatic increase in the number of codes. The number of diagnostic codes is going from about 15,000 to almost 70,000. The hoopla about that's died off a little bit. The delay a year ago was tied to the sustained growth rate fix, but that has been permanently corrected. The AMA's even dropped its opposition to ICD-10. Now, Medicare, and I know your patient population is not full of Medicare patients, they have said that they're going to have a year of forgiveness. If we make little errors in ICD-10 coding, they're going to forgive that. We've not heard the same declarations from Blue Cross, from Aetna, from United Healthcare. We don't know what they're going to do. So we're going to talk about some cautions in that regard. One of the reasons the big hoopla about the increase in number of codes has sort of died off pretty quickly is that half of the new codes just have to do with the musculoskeletal system. A full third of them is just because we added codes for left and right, and for some things bilateral, and for some things unspecified codes for laterality. And we do exercise some caution. If the payers know, we know if something's left or right, and we don't say in our codes, that gives them an excuse not to pay the claim. So we want to be careful about that. So by law, and not the Affordable Care Act, but the HIPAA legislation from back in 1996 stipulated that when ICD-10 goes into effect, all diagnoses have to be made in ICD-10, regardless of where the diagnosis is made, in the hospital or in the office. They have to be coded into ICD-10. Now, they've taken the procedure codes and put them in their own separate system, ICD-10 procedural coding system. Only the hospitals use that. And they're only for inpatients. So office procedures, CPT codes, observation patients in the hospital but not in inpatient status, that's all the facility bills CPT codes. CPT does not change. Physicians bill CPT codes all the time, regardless, anywhere. In ICD-9, the code structure, 5 digits long. Use your imagination to picture a Southern California freeway that's 5 lanes wide and it's just clogged, it's full, nothing's moving, there's no room for anything else. That's ICD-9. In ICD-10, it's a 7-digit code, and for several of these, it can either be a number or a letter, which creates 34 possibilities within that column. So picture a 34 stacked deck highway. You can put a lot of cars on that, so there's big room for expansion. Some changes, obviously a lot of new conditions since the last revision, new categories for post-procedural incidences, adding left and right, much more in the way of diabetes and injury codes. And there's so many complications of diabetes. Most of them arise in the adult population. But anytime we see one, it almost always increases the relative weight when we link it to diabetes. If they have gastroparesis, if we say, autonomic neuropathy due to diabetes, we get extra credit for that. There are new combination codes. The fast food industry is way ahead of us on that. You go to McDonald's and order number 1, and you're getting a list of things. And so we're catching up on that. The inclusion of trimesters in pregnancy codes. Many codes are divided into first, second, and third trimester. Obstetricians and everybody typically documents in gestational weeks. The coders can translate that into trimesters, so we don't have to worry about that. So why do we care about this? Well, we're being graded now for quality of care and cost efficiency of care, and these assessments have been available to insurers for a long time. I don't know if you noticed in late 2013, about a year and a half ago, United Healthcare dumped thousands of doctors off their provider rolls, took them out of network because they were deemed not to be cost efficient. And these assessments are going to be increasingly available to the public on government websites. And they're going to increasingly link our reimbursements from Medicare, but also private payers as well, and it may include Medicaid. So our medical language that we use with each other, that we document in the medical record is one thing, but then there's this administrative language that our medical language, if it's like a phone book, there are numbers next to each condition, and that's what goes on into being processed. So just a little bit about those languages. The three major ones are the MSDRGs. Medicare obviously uses the Medicare Severity Diagnosis Related Group, and many privates do as well. Only for inpatients. APR-DRGs, again, only for inpatients. Medi-Cal uses this system. And the HCC's hierarchical condition categories, they're used in inpatient and outpatient. So any ICD-10 code now that's attached to a patient from any location can go into the HCC methodology. But these are processing languages that are used for billing and reimbursement, statistical analysis, quality analysis, and cost efficiency analysis, but they're all designed to communicate the patient's severity of illness. Within the Medicare system, secondary diagnoses are classified by their level of severity. It's a three-tiered system that revolves around a term called a CC. One C stands for comorbidities, and that's every condition the patient has before they get admitted to a hospital facility. And the other C is complications, conditions that arise anew after the inpatient order is written. And then an MCC is just a major one of those. So the three tiers are MCC, highest level of severity, CC, and then neither one. And for terms that are in that category, we get no increased relative weight for that at all. In the APR-DRG system, there are two categories. One is severity of illness, the other risk of mortality. And each of those categories has a number score between 1 and 4. 1, not very sick. 4, very, very sick. And the two numbers don't have to be the same. They can be different. In the hierarchical condition categories, every diagnosis has a fraction of a number of relative weight assigned to it. And for all of those secondary diagnoses, for a single patient, those relative weight numbers are added together, and the total number gives you an idea of the patient's severity of illness. And these are called outpatient DRGs because these accumulate from wherever any diagnosis is made, and they're the categories that are used to fund accountable care organizations, which Medi-Cal has some. And the HCC category is particularly important to us because the HCC methodology is what Medicare is using to adjust the value of reimbursement back to physicians for Medicare patients. It's also what they use to identify their cost per beneficiary expense, and it's what they use to fund accountable care organizations, independent practice organizations, which are growing in number. Now, just some ICD-10 basics. Coding is based on physician documentation. Coders cannot assume anything. If we write down glucose 230, but don't use the term hyperglycemia, they can't code hyperglycemia. We have to use the term. Same thing, sodium up or down, potassium up or down. We have to use hyponatremia, hypokalemia, those sorts of things. And they can code from the record of any licensed practitioner that has face-to-face contact with the patient. Physicians, nurse practitioners, PAs, RNs and LPNs, they cannot. And they can't code from X-ray reports because the radiologist doesn't have face-to-face contact with the patient, except when the attending of record notes the primary finding on a radiology report. Then the coder can go to that report and get additional information describing a fracture and that sort of thing. But we have to acknowledge the fracture or the pneumonia or whatever. Coders cannot use path reports, but when we bring the diagnosis into the medical record, they can use the staging forms as well. Now, one thing that's helpful for inpatients, this doesn't apply to the office setting, doesn't apply to the emergency department, doesn't apply to anybody that's not in an inpatient status. If we have an uncertain diagnosis, somebody's hospitalized with pneumonia, and we hardly ever know the precise name of the organism that's causing the infection, but we can qualify that diagnosis as possible, probable, likely, And if documented at the time of discharge, then the coders can code that diagnosis as if it was established in fact. So if a kid has, community-acquired pneumonia and we think it's pneumococcus, they hadn't had a vaccine or something, we can say probable pneumococcal pneumonia, and they can code it as pneumococcal pneumonia. Now this only works for inpatients, and it doesn't have to be pneumonia. Any uncertain diagnosis at the time of discharge from inpatient status can be used to do that. Now, it doesn't work for HIV. If somebody is HIV positive but has not yet manifested symptoms of an AIDS-defining illness, or their CD4 count has not dropped to an AIDS-defining level, then the state of California forbids coding that patient as HIV positive. We just have to ignore it. But if they do have an AIDS-defining illness or AIDS-defining CD4 count, and they get started on antiretrovirals, for the rest of their life, they have AIDS, because it's going to be treated with antiretrovirals for the rest of their life. And that's one thing that's helpful. Sometimes it's obvious the condition you're treating with the medication you're treating. If somebody has diabetes and they're on an antihyperglycemic, then we know they have diabetes. If somebody has hypertension and they're on an antihypertensive, even though their blood pressure is normal, they still have hypertension. So as long as we're treating AIDS with an antiretroviral, they may be totally asymptomatic, but we're still treating that condition, so we name that condition. As long as you're actively treating the condition, even though they're asymptomatic from the condition, then you code the condition. They will code. You diagnose the condition, and they will code the condition. Like Hodgkin's. As long as somebody is been diagnosed with Hodgkin's disease, is being treated for Hodgkin's disease, then it's diagnosed as active disease, and you get credit for that. Once it goes into remission, once you're not treating it in any way, shape, or form, sometimes, it rears its ugly head again. We don't want to forget about it. So it goes into a category called history of. Now, that phrase has been used ambiguously in our, medical practice, because we're taught, as medical students, if I say somebody has a history of hypertension, diabetes, emphysema, I'm communicating they still have that. But the coding system, when they see the term history of, it means they had it, they don't have it anymore. It's gone. And we're not doing anything to treat it now. But it's important enough to keep on the problem list so we don't forget about it. So for accountable care organizations, HMOs, and that sort of thing, we don't get any additional resources to care for that, but it stays on the list so we don't forget about it. As we're getting increasing use of electronic health records, we've noticed that some of them have a category, and pull down, and you can, one of the options is history of, and we may be, history of this, history of that, and we think we're populating the medical record with the conditions the patient has, but if we attach the phrase history of to it, we're saying they don't have this, they don't have this, they don't have this. So we need to use caution with that. So history of means it's gone. I have a history of strep throat, but I don't now have strep throat, and I have no sequelae of strep throat. Status post only links something in time, not in causality. So one of the things that we need to adjust our nomenclature, our vocabulary habits, is to try to link things, caused by, due to, resulting in. Most of the time when we do that, we get increased relative weight. We can have somebody that's 2 weeks after chemotherapy that happens to be neutropenic, but when we say neutropenia due to chemotherapy, the relative weight goes up. Every time we see a condition, if we ask ourselves, why do they have this? How did they get this? And if we can link that, then the relative weight goes up. Sepsis due to pneumococcal pneumonia. This is a general equivalence mapping table. In ICD-10, asthma is coded as either extrinsic or intrinsic, terms that I haven't used since first year of medical school. Those terms are going away. You can see how it's coded in ICD-9, the name, the codes in ICD-10, their name, and whether it's an approximate match, an exact match, or there's so many options you need to consult the tables. Now, one of the things that we're going to provide for you is this table that has every ICD-9 code and every ICD-10 code and its exact match or approximate match. And what a lot of office practices where they do their own coding, this can be helpful if you identify your top 10, 20, 50 ICD-9 codes and just kind of see what the options are in ICD-10, so you can kind of be thinking about how your nomenclature needs to adjust. Then going from September 30 to October 1st It's just another day of the week. Now, I would caution you not to print this table. It's 2,400 pages long. But it's searchable. Up in the right corner, you can type whatever condition you want in there, and it'll go right to it. And then many other things that you're interested in are in that same neighborhood. There will be PDFs of the slide set in color and black and white for the handouts that will be available to you. Because in the back, there's slides that we're just not going to have time to get to. And there's more detail about malnutrition and several other things back there that may be of interest or entertainment to you. Here's an example of serous otitis media. In ICD-10, we've got left, right, bilateral. And then there's a code available for unspecified ear when we don't put it down. But again, if we don't write it down, we're concerned that they just may decide that they don't have enough information to process the claim. So here are the things we do a lot in the pediatric office. Lots of asthma, lots of developmental issues. Now, in an ICD-10, there's just a great expansion in the options for coding, even office visits. If we have an examination without abnormal findings, there's a code for that. If there's an examination with abnormal findings, there's a different code for that. So you need to make it obvious to your coders that this was a normal exam or this was not an normal exam, so they can start with the basic first early codes. And there's a variety of reasons that people come to your office for examinations, and there are codes for a whole lot of those. Whether it's a psych eval that's at official request, a school exam, residential exam, driver's license exam, sports participation exam, insurance exam, adoption exam. So there are lots of different options for that. Many different codes for developmental disorders, other issues, autistic disorders. Because there's such a big increase in the musculoskeletal codes, people think the orthopedists are getting hit the hardest. I think it's the psychiatrists. Because in ICD-9 and the DSM-5, the descriptive numbers and the code numbers were the same. In ICD-10, we just screwed that totally up. So the psychiatrists, if you have to consult them after October and they seem a little frazzled, that may be why. They need compassion, and they're going to need each other. And the autistic Asperger's syndrome, now they call it the spectrum of autistic disorders, and they had all that worked out, but the ICD-10 coding system doesn't accommodate the latest literature in psychiatry, so it's all messed up. Vaccinations, notice in ICD-9 we had different ICD-9 codes for the different vaccinations that we provide. In ICD-10, there's just one code. All the vaccines go to one code, but they will still be able to identify who got what, because the CPT codes that you submit will be labeled for the different vaccines. So I was scratching my head for a minute at this too, and I just, the bureaucracy that created this is just massive. Can you imagine the number of people sitting around tables going, well, let's do this. Well, what do we do that? Okay, well, let's do that. It's amazing. So non-suppurative otitis, serous otitis, left, right, bilateral, and unspecified. And lots of codes for tobacco smoke, exposure in the perinatal period, history for your children who have quit smoking, your child bartenders that have occupational exposure, dependence, and use. And anytime, your adolescents, we're human beings taking care of human beings, and they get into stuff. If anybody has symptoms of withdrawal from their substance abuse, we get extra credit when we note the symptoms of withdrawal. For suppurative otitis, there are different codes for acute, recurrent, and if they have spontaneous rupture of the eardrum. So there's lots of information they're wanting to attract with this. I think in ICD-10 we have a new code for human metapneumovirus. I don't think there's one in ICD-9. Asthma, you're familiar with the new classifications for asthma, intermittent and persistent? Okay. This table kind of blew me away at first, but I'm beginning to get comfortable with the nomenclature. This is just their baseline severity of illness, intermittent versus persistent, and within persistent, mild, moderate, or severe. In ICD-9, it was easy. We had asthma. In ICD-10, we have their baseline characteristics, intermittent, mild, moderate, or severe persistent. And then within each of those, we have the option of uncomplicated, which means you're seeing them for something else, with acute exacerbation or with a status asthmaticus. So my sense is that any kid that can't go home from the ER is in status asthmaticus. They just have to be. And then, most of those will just get admitted to OBS. But if anybody ever makes inpatient status because of an asthma exacerbation, it's got to be status asthmaticus. I don't know how many kids I've seen that I could have labeled as status that it just never crossed my mind. I remember when I was at Vanderbilt, somebody came to tell us you have to stop diagnosing people with asthma. We don't get paid for asthma. And I'm sitting there, I didn't hear a thing she said after that. Now, she may have told us why and explained what to use acute exacerbation or status asthmaticus, but my brain just went, but they have asthma. What do you mean we can't call them asthma? That's why they're there, they have asthma. I understand now. One of the big things in ICD-10 is acuity. Acute versus chronic versus acute on chronic. And so the system, again, makes no assumptions. They had asthma last week, they weren't in the hospital. What changed? They have an acute exacerbation. Oh, okay, that's right. Or they're in status asthmaticus. Okay, that's what changed. Again, general equivalent mapping table, asthma, and all the different options. Mild, intermittent, uncomplicated, mild persistent, moderate persistent, just so many options. Now, I thought I was doing kids a favor when they had not yet been diagnosed with asthma, but they came in wheezing. I would call it reactive airway disease, so as not to label them with asthma. It codes to asthma. I was only making myself feel good. I was helping nobody. Well, I would help, how they felt. So we either need to call it what it is, RSV bronchiolitis or human metapneumovirus bronchiolitis, or asthma if it meets the appropriate criteria. Or, if you don't want to go that far, just, wheezing and acute bronchospasm, just call it symptomatically. So I don't use RAD anymore. Sepsis, the surviving sepsis literature has helped define this a bit. Fever, tachycardia, tachypnea, leukocyte, white count too high or too low for age. An infection that's either suspected or proven, doesn't have to be proven, and systemic inflammatory response syndrome of white count, tachypnea, tachycardia, sort of thing. And severe sepsis is sepsis with organ dysfunction, hypoxia or decreased urine output, elevated creatinine, except in neonates their creatinines are all across the board, they change too fast. And septic shock is sepsis and cardiovascular organ dysfunction, which in a kid may just be manifested as pallor, mottling, cyanosis. If their blood pressure drops, oftentimes, they'll hold out until the very end. Oftentimes that's too late. Now, in ICD-9, SIRS, the systemic inflammatory response syndrome, can either be of infectious or non-infectious etiology. In ICD-10, the systemic inflammatory response syndrome has nothing to do with infections anymore. It's all non-infectious causes. So SIRS can be from tumor lysis syndrome, from major trauma, major burns. But if we think somebody is having an inflammatory response due to an infection, we have to go old school and just call it sepsis. Not SIRS due to infection, but sepsis. Acute respiratory failure. In ICD-10, there are new codes for acute hypoxic respiratory failure and acute hypercapnic respiratory failure. And these following things meet the criteria for acute respiratory failure. Well, we'll start at the bottom. If they have to be intubated and mechanically ventilated, that's obvious. But we can use non-invasive ventilatory assisted methods. We can also use what we think may be more of a short-term hypoxic, say high flow nasal cannula or an FI2 greater than 30% if it's a condition that we think, if remained untreated, could be acutely life-threatening over time. But as we intervene, we may be able to turn them around quickly, like status asthmaticus, for example. Chronic respiratory failure is a process that requires continuous home oxygen or ventilator support, or having a baseline SAT less than 88% on room air, not just a spot check, but persistent, or a PCO2 greater than 50%. And acute on chronic is an option as well. So hypoxemic respiratory failure, classic definitions, PO2 less than 60, but since we've had pulse oximeters, my blood gas drawing has dropped probably 98%. Consistent SATs below 88%, because we're all familiar with the oxygen hemoglobin dissociation curve and how it drops off precipitously at about this level. And mechanical ventilation, obviously, supplemental non-invasive ventilation to high flow O2, which usually accompanies frequent hovering over the patient to see what else can I do to keep from having to intubate this person, and that's usually ICU or ER types of settings. If it's not an acutely life-threatening scenario, we can just document hypoxia alone. Hypercapnia, acute hypercapnic respiratory failure, PCO2 greater than 50, and stages of shock, compensated when the blood pressure is still intact, hypotensive shock, which is not a good sign in children, hypovolemic, distributive, vasodilation of sepsis, anaphylaxis, neurogenic, cardiogenic, and obstructive. So here's a case example. A little bunchkin, 2 weeks old, has a nasal congestion cold, poor feeding, decreased urine output, crying, has rhinorrhea and cough, fever at home but not too high, rectal temp 100.8, decreased PO intake and decreased wet diapers. So on exam, she's got a nasal discharge, she's tachycardic, tachypnic, capillary refill's a little delayed, and there's mottling. So that's kind of a red flag. We give her a fluid bolus, and because she's so young, we don't use the lactate levels. In older kids and adult, we can use that as a secondary physiologic marker of decreased tissue perfusion that supports a diagnosis of compensated shock, but we can't use it in little kids. So the resident says we've got a 2-week female with cough, rhinorrhea, and the RSV is positive, and they did an LP, it had clear fluid. The attending says 2-week-old female with RSV, bronchiolitis, fever, tachycardia, and respiratory distress. But let's look at consideration of diagnosis of shock. If somebody looks good and has an increased work of breathing, that may be respiratory distress. If they don't look so good and their work of breathing is decreased, well, that's consistent with respiratory failure or perhaps even impending respiratory arrest. So we need to be a little cautious about diagnosing those things. So the definition of shock is not a blood pressure definition. It's inadequate tissue delivery of oxygen and nutrients to meet metabolic demand. And some can be cardiac high output. Now, we get increased credit for the diagnosis of shock, but if we can describe it, categorize it, cardiogenic, septic, hypovolemic, traumatic, we get that increased relative weight at that highest level of the MCC. And so this is how we impact in the APR-DRG system, which is what Medi-Cal uses. We get the most minimal credit for terms like low blood pressure, hypovolemia, pallor, tachycardia. But if we say shock of any kind in the APR system, we get the maximum credit for that. And it can be, same patient, same doctors, same nurses, same intervention. It's not really a quality of care issue at all. It's just getting credit for it. When they do these quality of care analyses, cost efficiency analyses, they're not looking at our charts. They're not talking to our patients or their parents, all of whom love you, I'm sure. They're looking at those billing records that have all these ICD-9, ICD-10 codes, and looking at the accumulated list of those codes, and through that they define how sick the patient is. They look if they were hospitalized, how many days they were in the hospital, how much we spent taking care of that, and that's how they're coming up with these cost efficiency determinants. And it's all the numbers, and they start with the words that we use on the chart to describe the patient's condition. Hypoxemic-ischemic encephalopathy, mild, moderate, or severe. Any level is a secondary diagnosis at that mid-level of accreditation, but severe HIE is the highest weighted. If we just use the term neonatal encephalopathy, we get no credit for that. It's neither that, it's neither that. It's in that third category of not getting any credit for it at all. Nutrition, malnutrition in particular, is underdiagnosed at every hospital in the country with very few exceptions. And it's an opportunity to capture secondary diagnoses that can go toward the description of the patient's complexity of care, complexity of illness, and severity of illness. There are new criteria from the ASPEN Society. For a time we used secondary markers like albumin, prealbumin, those are out. There are new criteria, and the nutritionist for inpatient admissions can help identify these. This is the prevalence in a pediatric patient population. A little over 1% are thought to be severe, a little under 6% moderate, mild malnutrition 70%, but most don't have. But we get increased relative weight for any category of diagnosis of malnutrition whatsoever. And diseases that predispose people to malnutrition. Most of these are diseases of old people, but occasionally we see kids in these states. Body mass index is used predominantly in adults, but it hadn't been validated in the littlest of our people. So they have these Z-scores, and we have references to the literature that describes those. Are you familiar with the Z-score terminology? Is this, no? Okay. So we've got these references for you that may help out significantly. And they're categorized to tell you where you stand on this sort of thing. Mild and moderate malnutrition are secondary diagnoses at that middleweight cc of extra credit, and severe malnutrition has extraordinary increased relative weight. So in the APR system that Medi-Cal uses, just obesity we don't get much for. Morbid obesity we get a little bit extra credit for. Failure to thrive, terms we use all the time. Mild malnutrition, moderate malnutrition. The APR-DRG system is a bit more refined. Mild and moderate in the MS-DRG system are categorized the same, but for moderate malnutrition in the APR system, a little bit increased relative weight over mild even, and then severe malnutrition, the highest level. And you can see the numbers aren't the same. The severity of illness is higher as we get more malnourished, but the risk of mortality doesn't go up as appreciably fast. So terms, abnormal weight loss, no extra credit for that. Mild or moderate nutrition, some increased relative weight in the MS-DRG system, and some private insurance companies use, most actually use this system. Severe malnutrition, major increased relative weight. With kidney injury, there's been the rifle criteria, pediatric rifle criteria. Persistent kidney injury is that which is not resolved within 48 hours of hydration, but when it doesn't normalize, the mechanism of that is acute tubular necrosis, ATN. However, in 2012, there's been a revision of definitions for this. So even if someone comes in dehydrated and their creatinine is elevated, we can diagnose acute kidney injury just from that. There only has to be a 0.3 milligram per deciliter increase from the baseline to diagnose acute kidney injury, or if it's an individual that has chronically elevated creatinine, it has to go up 1.5 times above their baseline. So if somebody comes in with an elevated creatinine and it goes down with hydration more than 0.3, then you can still diagnose acute kidney injury based on presentation. And even if it's just based on hypovolemia, then that still counts. Now, there's a problem with the neonates because their creatinine changes. This is just days of life, and it changes within a few days a good bit, so it's hard to use this in neonates. And just as a point of reference, we have creatinine values from Mayo Clinic in age, males and females. Some neonatal issues, respiratory distress, and some different causes of that. If we identify someone in respiratory distress and can link it to the cause, caused by, due to, or reverse it, resulting in, then most times we get increased relative weight for that. Respiratory distress and respiratory failure in newborns, the RDS types, and you can see type 1 has a very high severity of illness and risk of mortality. Just transient tachypnea, not much in the way of increased relative weight for that at all. It's the lowest level. But respiratory failure in newborns, severity of illness very high, risk of mortality very high. And there are different codes for congenital versus acquired conditions, including findings and infections. Integral to the 4 key components in the tetralogy of Fallot would not be separately coded since tetralogy of Fallot has its own single code. NEC, any stage of necrotizing enterocolitis is a diagnosis at the highest level of severity within the MS-DRG system, but you can see if it's a Medi-Cal patient that we need to note particularly the stages, whether 2 or 3, because the relative weights go up dramatically with those. Codes for growth and fetal malnutrition, light or small for gestational age, slow fetal growth. When you go from 15,000 to 70,000 codes, there's a lot of new stuff in there. Infections in the newborn. And as we were talking earlier, when the causative organism is known or suspected, we can use that information to get credit for what we're doing. And this specifically goes to what we were talking about. A newborn may be admitted for observation, evaluation, and or treatment for a suspected condition found not to be present when the evaluation is complete. But clear provider documentation is essential for the rationale for the evaluation, observation, treatment, and the conditions ultimately ruled out. So we can use phrases like newborn suspected to be affected by maternal use of drugs or addiction, newborn suspected to be infected by exposure to organisms at the time of delivery. So, they've tried to make codes for everything that we do so we can get credit for what we're doing. And anemia caused by due to, resulting in. Jaundice in the newborn due to swallowed maternal blood, drugs, polycythemia, associated preterm delivery due to hepatocellular injury. Now, we're being asked to describe a few more of the trees to justify calling it a forest. So my partner, Dr. Jim Kennedy, who's been doing this for way more than a decade, came up with this mnemonic. It's music. We're from Nashville, easy for us to remember. The M stands for manifestations, those presenting signs, symptoms, syndromes, the first thing you see, the first thing you hear. U is the underlying cause. S makes us pause to ponder the severity or specificity. I, instigating a precipitating cause, what sort of condition or circumstance set them up for this illness, and consequences or complications. So we don't have to remember 70,000 codes. When we identify a condition, if we plug it into the mnemonic and think about the other components, anytime we can link condition and cause, condition and consequence, caused by, due to, resulting in, we can get additional credit for that in most instances. So here's, in the most simple example, somebody with a fever, white count, pleuritic chest pain, abnormal chest X-ray due to pneumonia. So we stop. Does this patient meet the criteria for sepsis? Might they be at risk for aspiration? Could it be caused by some other precipitating factor? Consequences or complications? Might they have sepsis or acute respiratory failure or empyema? Caused by, due to, resulting in. Now, for hospitalized patients, Dr. Kennedy came up with this rule of 3. And this is to put at bay the review audit contractors. There are people out there working for Medicare and private health insurance companies that love to take money away from doctors and hospitals. So if we define a condition, but not convincingly so for the review audit contractors, they can take the diagnosis away and they make their living by accumulating percentages of the money that they take back. So I could write, in the hospital progress note today, which is Wednesday, sepsis, and the coders could legitimately code sepsis. But if that's the only place in the chart that word appears, the review audit contractors are going to say, you didn't really mean that, so we're going to take that away from you. So we want things to be listed at least 3 times on the history, progress note, discharge summary. Because Dr. Kennedy and I are competitively OCD, I thought it'd be fun to have 3 rules of 3, so I made up 2 more. The second one is parts of speech. The condition is the noun. An adjective, describing word, acuity. Is it a condition they've had that changed? What changed about it? Acute, chronic, acute on chronic. Linking, which I know is not an adjective, but just, caused by, due to, resulting in. And if they're in the hospital or you're seeing them serially in the office, how's it going? Are they better, worse, same, or did it resolve? And then the third part of speech is the verb. What are you going to do about it? What are you doing about it? What did you do about it? And for inpatients, once on the problem list, always on the problem list. We want to preserve the condition for the discharge summary. Every hospital we go to, we review charts, and I can't tell you how many times I've seen a patient admitted to the hospital for pneumonia, treated for pneumonia, recovering from pneumonia. You read the discharge summary, the word pneumonia is nowhere to be found. People get better, we forget about it. So we want to preserve them for the discharge summary and cite as new any condition that begins after the inpatient order. But if we identify a condition after they've been admitted, it's not in the H&P, it's not on the first problem list. If we know after we recognize it that it was in fact present on admission, we need to say that, because there's a list of hospital-acquired conditions that if that diagnosis comes up on that list, even though it has increased relative weight in the Medi-Cal APR-DRG system or in the Medicare CC, MCC, that sort of thing, if it was not present on admission, we as physicians don't get that extra credit toward our quality of care scores, cost efficiency scores. The hospital doesn't get that increased relative weight to add toward their DRG reimbursement. So it's important when we identify something that was present on admission but is identified on hospital day 2 or 3 that we note that it was present on admission. But things, pneumonia gets better, acute respiratory failure gets better, status asthmaticus gets better, status epilepticus gets better, so we don't want to forget those things. So if they do resolve, leave them on the problem list, just comma, resolve. So when it's time to do the discharge summary. There are new codes in ICD-10 for patient noncompliance. So, I mean, we've always been able to protect ourselves from bad outcomes by documenting in the medical record noncompliance. In ICD-10, there are codes for that go out into the world, and so they'll be able to do research on groups of patients that are deemed to be noncompliant and their complication rates and long-term disease tracking rates versus patients that are compliant. Does the name Ezekiel Emanuel mean anything to anybody? He's the brother of Chicago's mayor, Rahm Emanuel. He's a physician. He's been very involved in the creation of the Affordable Care Act. He said we expect 20% of hospitals to close. Really? That's a lot. But it's going to be hospitals whose medical staff doesn't gather like this to understand, there are terms we get credit for and terms we don't get credit for. So when they hospitalize patients with pneumonia, that instead of a simple pneumonia, they have a complex pneumonia, but it's not even just a complex pneumonia. They have acute respiratory failure, or they have sepsis, so they're taking care of somebody that's this sick, but it gets coded out as simple pneumonia, so they're spending this, they're getting reimbursed this, no margin, no mission. You can't survive that. And so those hospitals are going to fail. They won't have enough money to keep the doors open. So at least we're getting there. Michelangelo at age 87 said, "Yet I am learning." He said, "If people knew how hard I had to work to gain my mastery, it would not seem so wonderful at all." So completely, totally, unofficially, just from me, if you are a practicing pediatrician or neonatologist and age 87 or older, you can forget everything you heard. But the rest of us need to pay heed, because it's not a quality of care issue, it's a getting credit for it issue. And I want you to get credit. We work hard and long to get where we are, and the screws are getting turned tighter and tighter, so we just need to understand the rules that they have prepared for us. I appreciate your time and attention. I hope this has been, if not a little enlightening, at least alleviate some of the fears and concerns about ICD-10 coming. It's not all going to be bad, but I think appropriately armed we'll be in a position not only to survive but to thrive. Thank you so much.